So today, continuing on with our renal module, it's been some days since I've recorded a lecture, and I thought maybe now it's time that I should continue with this. So we left off with discussing uh, potassium disorders, right? So we discussed hypokalemia, and in the video before that, we discussed hyperkalemia, right? And we are discussing the renal and genitourinary module from the first aid, step 2, CK book. Right, so starting off with hypercalcemia, and we're going to try to complete the calcium disorders in this video. So, hypercalcemia is serum calcium above 10.2 milligrams per deciliter. You should know the normal value, which is from 8 to 10.5 or 10.2. So you should know that, right? So let me write it in a bit of a organized manner. So from 8 to 10 approximately is the normal value for calcium. So any serum level above 10.2 or 10 is hypercalcemia. Now you need to understand that this is what is written here is corrected for serum albumin. So that's what's written here. So what is this? You need to know that why is this written? What is this? What does this mean? So does anybody have any idea of what does this mean? So what does this mean? The correction for serum albumin. What this basically means is that hypoalbuminemia can hypoalbuminemia can cause a falsely low total serum calcium because a significant portion of calcium is bound to albumin. So the ionized free calcium, which is the physiologically active form, is typically normal. So what happens is that let's say, for example, this is the albumin molecule, and this is calcium. So what happens is that most of the calcium is carried with albumin, right? So this is the physiological form, or basically the storage form of the calcium, if you will. So in this form, calcium has no charge, right? You know that calcium has normally it has a +2 charge. So in this form, calcium has no charge. So the calcium is neutral, chemically neutral, right? And this is basically you can say technically that this is the storage form, right? Now, when something is in storage, you don't need it to be active. So this is also inactive, right? Because it has no charge in it. So the chemical composition of it is shut down temporarily, right? So this is the inactive form. The charge version, however, is the active form. If we could say it, this is the active form, right? So this naturally would mean that this would lead to its functions. So what happens is that this part is not giving rise to the functions of the calcium. This part is. So what happens naturally that if albumin, for example, if there is decreased albumin, if there is decreased albumin, what happens is that the calcium levels also decrease because this is what is basically this part is what we see when we measure for calcium, right? So if albumin is decreased in the blood, then calcium is also decreased. So what happens is that hypoalbuminemia causes a falsely low total serum calcium because most of the calcium is bound to albumin, right? So if this complex, this compound in itself, if this is all of this is decreased, then the total would also be decreased, right? The total would be decreased. So when you measure the calcium in these kind of patients, what happens is that you get a low total serum calcium level, So automatically you infer from that result that the patient is having a deficiency of calcium. However, however, the ionized calcium is mostly normal, right? So this calcium, which we do not measure from a typical electrolyte or a calcium test, serum calcium test, we do not measure this compound. We don't measure this one, the active form. This oftentimes is completely normal, right? This oftentimes is completely normal because this, of course, is not dependent on albumin, right? So you need to keep this in mind. However, we are discussing hypercalcemia, but this concept is important for you to understand is that whenever there is hypocalcemia or wherever there is hypercalcemia, we always have to correct for the albumin levels in our body. And there is a way of how we do that. So we use the correction formula when for hypoalbuminemia. This is the formula that we use. And the basic principle is for every 1 gram per deciliter of albumin below 4, add zero point 0.8 milligram to the measured total calcium. Right, so albumin levels are 3 to 5, I guess. Let's confirm it. Let's confirm it. So yeah, so 3 to 5 approximately. So the average normal value is 3 to 5. So every 1 gram per deciliter decrease in albumin below 4, you add a zero point 0.8 milligram per deciliter to the measured total calcium. Right. So the corrected calcium formula is the measured total calcium, which is given in the question, plus zero point 0.8 times 4 minus the measured albumin. Right. This would be given in the question as well. So you need to remember this formula. All right. Mostly this is not something that is very important to do, but there are some questions in the paper that might trick you. Mostly they don't trick you like that, but sometimes in some questions which are present in the NBMEs, they do tend to test this concept. So if you know this might make a lot of things easy for you. So this is the formula for corrected calcium. I've given an example as well. If measured calcium is 7.6 in the question and the albumin is 2, the formula basically is 4 minus 2 times zero point 0.8, which is 1.6, and then you add 1.6 to 7.6, right? And you get this. So in the question, they gave us a calcium level of 7.6, which is obviously low. But when we used the formula and we corrected it, then we got 9.2, which is normal. So that's why this is important. The use of this is you always check ionized calcium if available, most accurate. But this is not always available. The routine test that we do is serum calcium, which measures the total calcium. So if you have a chance, you check the ionized calcium levels. If you don't, then you use the correction formula when ionized calcium is not available to avoid misdiagnosing hypoalbuminemia as true hypocalcemia. So most of its application is in hypocalcemia, but since it was described here, so I thought I might as well explain it. So if even in hypercalcemia, you correct it for serum albumin, mostly it is used for hypocalcemia, but sometimes you can use it for hypercalcemia as well. All right, so then we call it true hypercalcemia now. Assuming that we have corrected it for albumin, now we're calling it a true hypercalcemia. And the most common causes are the following: hyperparathyroidism, malignancy, and other causes. So I'm going to explain all of them one by one, but after we read the history a bit, right? So the history or the physical examination is usually asymptomatic, but can present with bones, which is osteopenia and fractures, stones, abdominal groans, stones for kidney stones, abdominal groans, and psychiatric overtones. Right, so bones, stones, groans, psychiatric overtones. This is in itself a mnemonic that is mostly used. So for bones, we mean osteopenia and fractures. Stones, we mean kidney stones. Abdominal groans. By abdominal groans, we mean anorexia, constipation. And psychiatric overtones, we mean weakness, fatigue, irritability, and altered mental status. So now I'm going to explain the causes of hypercalcemia, which they have summarized over here with the mnemonic of chimpanzees. So if you want, you can use this as well. But these are the different causes. So calcium supplementation, hyperparathyroidism, hypothyroidism, iatrogenic, which includes thiazides, and parenteral nutrition and immobility as well, especially in the ICU setting. Milk alkali syndrome, Paget disease, adrenal insufficiency, acromegaly, neoplasm, Zollinger-Ellison syndrome, excess vitamin A, excess vitamin D, sarcoidosis, and other granulomatous disease. So I'm going to explain all of these so that for each uh, etiology, you must know the mechanism by through which it is causing the hypercalcemia. Mostly, this is pathology, not really medicine related, but it is important for you to understand. Also, after explaining these etiologies, I will also explain the presenting features of the condition. Right, so let's go over here to our notes and we'll see. So, calcium supplementation, first of all, is quite self-explanatory. Dietary directly increases serum calcium levels, particularly if excess or with concomitant renal impairment. So, if you take more calcium, you get more calcium. So, that's very simple. Hyperthyroidism or hypothyroidism. So, primary hyperparathyroidism, what it does is basically increase in PTH would lead to bone resorption and renal reabsorption. So, what we're saying is, if I could clear this up. So, what we're saying is basically uh, increased PTH would lead to increase bone resorption and increase uh, kidney reabsorption. So it's going to basically take calcium out from the bones. So it's going to make bones weak, right? It's going to make bones weak. So you have to keep that in mind. So PTH uh, results in increased bone resorption and renal reabsorption, which is the most common which is the most common reason. So the most common reason, if there was a question of the most common reason for hypercalcemia, so that would be increase in PTH. This is the most common reason, right? To keep that in mind. So the most common reason is primary hyperparathyroidism. Hypothyroidism rarely causes mild hypercalcemia, while decreased bone turnover reversal after treatment. So what happens is that in hypothyroidism, what happens is that bones get resolved, bones turnover increases, right? So bones break down and repair increases in hypothyroidism because it is a decreased metabolic state, right? So what happens is that when you start the treatment for hypothyroidism and the bone turnover decreases, if I could explain it better over here. So what happens hypo in hypothyroidism? So TH is for thyroidism only, right? What happens is that there is an increase in bone turnover, right? So BT is for bone turnover. Why does it happen? It's not necessary for you to know why this happens, but it happens due to an abnormality in the metabolism of bone. So hypothyroidism causes increased bone turnover, which can also lead to fractures, right? So it can also lead to fractures in hypothyroid patients, in Hashimoto's patients also. So this is also something that you need to remember. So it increases bone turnover, which can lead to fractures. And when bone turnover increases, there's a decrease in calcium from the blood because all of this metabolism going on in the bone requires calcium, right? So what they will do is they will take calcium from the blood, and they will use it in this whole breaking down and repairing the bone process. What happens is when you start to treat hypothyroidism with levothyroxine, when you start to give patient thyroid hormone, this process decreases, right? So this process is inhibited. So the calcium that was first used in this process now, it is not being used, so it increases in the blood. So that's how hypothyroidism can lead to hypercalcemia. But this is a very indirect mechanism, something which is not really tested, but nonetheless important for you to know. So these are hyperparathyroidism and hypothyroidism mechanisms that cause hypercalcemia. Hydrogenically, if you haven't noticed, we're following this all of this, right? So hydrogenically, what happens is thiazides reduce calcium excretion, so they can cause hypercalcemia. Total parenteral nutrition may provide excess calcium. So when your total parenteral nutrition basically means is that you're providing parenteral nutrition to the patient, that he cannot take enteral nutrition and he cannot use the GIT for food consumption. So now you're providing total parenteral nutrition from the internal jugular vein or the subclavian vein, and in that you provide proteins, carbohydrates, vitamins, minerals, something, all of the things that are important for the patient. What happens is sometimes that you provide excess calcium, because calcium is also a part of that diet. So you provide excess calcium, which can lead to hypercalcemia. And lastly, immobilization increases bone resorption. So if a patient is not walking, is completely on bed rest, what happens is that physiologically, body says that I don't need all of this bone mass, because now that the bones are not bearing the weight of the body. So now the body thinks that since I don't need this bone mass, so what happens is that it starts to resorb some of that bone mass and release calcium into the blood. So that calcium then causes hypercalcemia. So body is quite smart. It realizes some of the things that it doesn't need, and it conserves the things that it needs. So for a patient that is completely on bed rest, it doesn't need calcium, or it doesn't need strong bones for that patient, right? So milk alkali syndrome. This is basically when you have a high intake of calcium uh, and alkali that leads to hypercalcemia and metabolic acidosis and acute kidney injury. So high calcium intake would be basically taking calcium supplements, and high alkali intake would look like a patient that has peptic ulcer disease or GERD, and he excessively is using antacids, right? So antacids contain these alkaline metals. So this is what basically this means is that this. All right, so let me check, and we're on. Right, so we were talking about milk alkali syndrome, so I hope it's all good. You've understood. So high calcium intake plus high alkali intake leads to hypercalcemia and metabolic alkalosis and acute kidney injury. I've also explained this whole process in my endocrine series as well. So Paget disease. What happens is that in Paget disease there is increased bone turnover, so they cause hypercalcemia. Paget disease majorly comprises of breaking down the bone, right? So majorly the bones are getting broken down, and when the bones are getting broken down, calcium is being released into the blood, which causes hypercalcemia, of course, especially during immobilization as well. So Paget disease causes mild hypercalcemia. Just keep that in mind. Adrenal insufficiency, acromegaly. So adrenal insufficiency causes volume depletion. We know that, and possibly increased bone resorption. Possibly, this is a possible relation that can happen. Acromegaly, on the other hand, increases the production of 125 dihydroxy cholecalciferol, which is vitamin D, right? So it increases the vitamin D production. So once vitamin D is now increased in the body, what happens is that vitamin D in itself is now will now cause the absorption of calcium. We've always heard that malignancy is a major cause of hypercalcemia. That happens through quite different, you may say, mechanisms depending on the uh, neoplasm that is occurring. So, if there is a squamous cell lung carcinoma, famously it can cause PTH-RP secretion, which can cause increased calcium absorption. Right? This would lead to simply as increased PTH levels in the body. This would mimic hyperparathyroidism, right? So PTH-RP would mimic hyperparathyroidism, but you must understand is that PTH-RP is not equal to increased PTH, right? So these both, although they work similarly, but they are quite different proteins. So you are not supposed to uh, consider them as one. So you're not supposed to consider that if there is increased PTH RP in the body, then there would always also be increased PTH. No, PTH will be decreased in this case, right? So if there is a squamous cell lung carcinoma, PTH RP would be increased, but PTH in itself would be decreased in the body. Bone metastasis, these may occur in breast or multiple myeloma. So if bone metastases occur, calcium is being released, bones are being broken down. So that's how they can cause hypercalcemia. Or if there is a lymphoma in the body, it can increase calcitriol production from the lymphocytes. And of course, increased calcitriol production would in itself lead to increased calcium reabsorption. So that's how these cause hypercalcemia. And Zollinger-Ellison syndrome, I guess this was remaining. Yeah, so Zollinger-Ellison syndrome that occurs in the MEN1 disorders that often co-occurs with hyperparathyroidism as well due to parathyroidadenoma in the MEN1. So Zollinger-Ellison syndrome is not directly the cause of hypercalcemia, but because it occurs in association with hyperparathyroidism, which we discussed earlier, how it causes hypercalcemia, then it is indirectly a cause. But I could say a better word for this would be that MEN1 is a cause of hypercalcemia. So MEN1 would be the cause of hypercalcemia, if I were to say that. Not necessarily Zollinger-Ellison syndrome. Zollinger-Ellison syndrome and hyperparathyroidism are a part of MEN1, right? Okay, so excess vitamin A, it stimulates the osteoclast activity and decreases bone resorption. So osteoclasts, basically, what they do is they break down bone. So they increase the osteoclast activity and then they increase bone resorption, leading to more release of calcium into the blood, causing hypercalcemia. Excess vitamin D, again, more calcitriol, which increases intestinal calcium absorption and bone resorption. And lastly, sarcoidosis or any granulomatous disease. So macrophages in granulomas, they basically convert the 25 hydroxy uh, cholecalciferol to active form. So basically, they what they do is they convert calcidiol. What they do is they convert the calcidiol to the calcitriol, right? So they're basically producing more uh, vitamin D. So vitamin D2 to vitamin D3, which is the active form, right? So and of course that would in itself lead to increased intestinal calcium absorption. So these are all the etiologies of hypercalcemia that why hypercalcemia can occur. All right, so we discussed all the etiologies of hypercalcemia. Now I want to discuss of the clinical presentation. Why do we get these bones, stones, abdominal groans, and psychiatric overtones in a patient of hypercalcemia? Why do we get this? So to discuss this, let's go over to our notes, and this is basically the, the brief explanation of the physical presentation of the patient with hypercalcemia. So, what does increased calcium in the body do to the patient that he gets these symptoms? That's what we are basically discussing right now. So, as far as central nervous system is concerned, which is the psychiatric overtones part of the equation, and it also causes fatigue and coma. As far as this is concerned, hypercalcemia depresses the neuronal excitability by raising the threshold for action potential generation. This manifests as altered mental status, ranging from fatigue and confusion to stupor or coma. Right. So, what basically they're saying is that there is a action potential graph, right, that you have studied. So this is the action potential graph. So to start this action potential, you need calcium, right? So you need calcium. So what happens is when there is hypercalcemia, when there is hypercalcemia, so more calcium is coming in, sticking to the channel that causes the that could start the action potential, right? So there is more calcium. What happens is that physiologically there is an adaptation in neuronal cells, in neurons, that causes them to raise the potential, raise the threshold. So this, if it was negative 65, let's say for example, this raises to 75, right? So now you need a lot more calcium to go and stick to the channel to generate an action potential. So you might be thinking that we already have a lot of calcium. What is the problem? The problem is that this adaptation occurs in throughout all of the neurons in the central nervous system. So the combined effect of this adaptation is far greater, which leads to these symptoms such as fatigue, coma, altered mental status. This is what you have to know, that hypercalcemia basically depresses the neuronal excitability by raising the threshold. So it is difficult to generate an action potential and carry the impulses throughout the central nervous system when there is hypercalcemia. The stones part of the equation uh, relates to the renal stones. So when there is more calcium in the blood, there is more chances of renal stones occurring. So what happens is that sustained hypercalcemia causes nephrogenic diabetes insipidus by antagonizing ADH action in the collecting duct, leading to polyuria and dehydration. Chronic hypercalcemia promotes calcium phosphate stone formation and can cause nephrocalcinosis, right, leading to impaired renal function, right. So there are two mechanisms occurring here. One in which hypercalcemia is leading to polyuria and dehydration. So there is basically less liquid into the collecting duct or throughout the renal system to dilute the calcium. So there is decreased liquid, decreased water. First mechanism is that. Then there is also presence of more calcium, and more calcium can lead to more binding of calcium with phosphate, leading to the increased formation of calcium phosphate stone formation. Right. So if there is more calcium, if there is more calcium, what it will do? It will bind to phosphate. So this is phosphate. So this would increase more calcium would increase the chance of this happening. And when this happens, this can lead to the stones, right? So you know that the most common stones, most common kidney stones are, I hope you know that the most common kidney stones are calcium oxalate and calcium phosphate. So both of these need calcium, right? So if you increase calcium in the blood, you cause hypercalcemia, it can lead to more formation of stones into the kidney. Nephrocalcinosis is just increased presence of calcium in the nephron, which basically is also interchangeably used for increased stone formation. So again, hypercalcemia can cause two things. It can lead to polyuria and dehydration, and it can lead to the stone formation by directly combining with increased phosphate present in the vicinity, which can lead to stone formation in the end and impaired renal function eventually. So that's how hypercalcemia affects the renal system, and then the patient mostly presents with a stone, polyuria, or renal failure if left untreated. Gastrointestinal abdominal groans, right? This basically means anorexia, nausea, constipation. What happens is hypercalcemia directly stimulates the calcium sensing receptors in the stomach, our intestinal smooth muscle, right? So in the stomach, our intestinal smooth muscle, leading to reduced gastric motility and ileus, which can cause constipation. It also promotes gastrin release, which can cause dyspepsia or peptic ulcers. So this is a bit of an important fact that you must remember, not very commonly tested, but still you must remember. But this one is essential for you to keep in mind because this is the most common reason, most common symptom. One of the most common symptoms is gastrointestinal symptoms that the patients present with, hypercalcemic patients present with. So how does that occur? That hypercalcemia directly stimulates calcium sensing receptors in the stomach and the smooth muscle, leading to reduced motility. They might depress peristalsis, leading to reduced motility and ileus, causing constipation. It can also lead to anorexia, nausea. Of course, the food is not moving forward; it's going to come backwards. Right. Finally, musculoskeletal. So, bone pain and weakness. Right. High calcium often originates from increased bone resorption. Of course, the most common cause of hypercalcemia is hyperparathyroidism, and the second most common is malignancy, right? So, which weakens the bones. So constantly bone resorption weakens the bones, causing osteopenia, pain, and pathologic fractures. Excess calcium also impairs skeletal muscle membrane potential, causing muscle weakness. So, it is causing bone weakness also, and it's causing muscle weakness also. How does it cause muscle weakness? Probably similarly, similarly uh, to its effect in the neurons, in which it was raising the threshold and it was impeding the generation of membrane potential. So that's how it's probably causing the same thing. But the most important in this whole explanation to remember is that it causes muscle weakness as well as bone weakness. So you're not basically expected to keep all of these things in mind or to remember all of this because it is an MCQ pattern test. So they will not ask you the mechanism for everything, but it is my job to teach you that how everything works, right? So that you have a very good understanding of how everything occurs, right? So moving on, the diagnosis best initial test is total ionized calcium, whichever is available. Ionized, of course, is better. You do albumin levels, you check phosphate levels, you also check PTH, you check electrolytes, BUN, creatinine, magnesium, alkaline phosphatase levels because these are the most routine tests that are done, right? These tests are very routine and they will be done if patient is presenting with any symptoms related to hypercalcemia. Also, you may consider parathyroid hormone related peptide if malignancy is suspected, so you can also check its levels. And serum protein electrophoresis can be done if multiple myeloma is expected. Vitamin D levels can be done if any granulomatous disease is suspected, right? This is not a routine test, but this is usually done if any granulomatous disease is occurring, sarcoidosis or Crohn's disease. Hydrogenic vitamin D intake should also be supervised, or if TB is expected, then of course do the you also do its test. So the also considered tests are some tests that are extra. These are not routinely done, but they must be done if you suspect any particular etiology like cancer or TB, right? Or if you think that the patient might be supplementing with vitamin D itself themselves. The treatment is better written over here that the immediate treatment for severe hypercalcemia, which is calcium above 14, or any patient that is symptomatic, regardless of the level of the calcium, you do IV isotonic saline, which is the first step, and this is the most asked in the paper as well. The first step is always IV isotonic saline. And then you go for the IV bisphosphonate, which is zoledronic acid or pamidronate, whichever one you prefer. These inhibit bone resorption, but they also require 2 to 3 days for peak effect. So the most initial step is IV saline, and then of course if IV saline is already given, you go forward for the bisphosphonate. You can also give subcute or intramuscular calcitonin, which has a rapid calcium lowering effect within hours. So this is not routinely done, but if they've asked you both, if they've given both isotonic saline and bisphosphonate in the question, and then they're asking that the patient is still having symptoms of hypercalcemia, and then what should be done, then you have to understand, then you have to give this as an answer, calcitonin, right? So after you initially stabilize the patient, or if the patient is presenting with just moderate hypercalcemia, not severe hypercalcemia, then what you do is you treat the underlying cause, right? So if surgery is the underlying cause, if primary hyperparathyroidism is the underlying cause, you do surgery for it. You stop any offending drugs. If there is a granulomatous disease, you treat it, or at least treat the flare that is happening, such as giving glucocorticoids. And if there is a malignancy, you also treat the malignancy. So this whole setup is done only when there is a severe hypercalcemia presenting acutely. Okay, with these symptoms, all of these symptoms. All right, so this is the diagnosis. One thing more in diagnosis is that ECG may show prolonged QT interval. Right, that is something that you have to keep in mind. That QT interval is increased in hypercalcemia, and this you may read it yourself, but I've explained everything in my notes, and this is just the reiteration of what we have discussed. Now we will discuss hypocalcemia. Finished up with hypercalcemia, and now we'll continue with hypocalcemia. So before going on to this section, I would like you to concentrate on this key fact right here present in the corner, this one. So this is saying that loop diuretics, just furosemide, lose calcium. So loop diuretics lose calcium. Thiazide diuretics increase tubular reabsorption of calcium. Right. So this the alphabet in itself is a mnemonic for you to remember that loop diuretics lose calcium. Loop diuretics lose calcium. Thiazide diuretics increase tubular reabsorption of calcium. So this is a short mnemonic, simple one for you to remember the relationship of diuretics and calcium. So loop diuretics would cause hypocalcemia, and thiazide diuretics would cause hypercalcemia. And thiazide diuretics also have this mnemonic of hypergluc. So they have this mnemonic of hypergluc, right? So they cause increased glucose, lipids, uric acid, and this is C. So hypergluc, so calcium. So these components are increased after you use thiazide diuretics. You can remember them as hypergluc, right? Hypergluc. So these components will be increased in the blood after you use the thiazide diuretics. Okay, so continuing on with hypocalcemia. Hypocalcemia is basically serum calcium less than 8.5. The etiologies include the following: parathyroid related are hypoparathyroidism, post-surgical or idiopathic, secondary hyperparathyroidism, CKD, and pseudo-hypoparathyroidism. In infants, consider DeGeorge syndrome, malnutrition, vitamin D deficiency, and others include hypomagnesemia and acute pancreatitis, chelation from citrate found in blood products. Now, I will discuss these etiologies one by one, as I did in hypercalcemia as well, because you need to understand the underlying mechanism of how each of these causes hypocalcemia. So I have my notes with me. I have my notes with me. But before that, we should also take a look at the history and physical examination so that we could discuss both of them together. So, history and physical examination, the patient will present with abdominal muscle cramps, dyspnea, tetany, perioral and acral paresthesias, and convulsions. Facial spasm elicited from tapping of the facial nerve, which is known as the Schoff-Textine, and carpal spasm after arterial occlusion by a BP cuff. It's known as the dorsal sign. Are classic findings that are the most commonly seen in severe hypocalcemia. So these are the physical examination findings that we will get, or how the patient is going to present. This is another key fact. A classic case of hypocalcemia is a patient who develops cramps and tetany following thyroidectomy because of parathyroidectomy as a complication. So this is also part of our explanation that I will be giving you. So now moving on to our notes, the notes that we have created, or I have created for your easiness, to explain you how these etiologies, how are these etiologies related to hypocalcemia, and how are they really causing hypocalcemia. So we will look at them now. Hypoparathyroidism, post-surgical idiopathic or DiGeorge syndrome, all of these, all of these cause hypoparathyroidism. All right. DiGeorge syndrome has a congenital absence of parathyroid glands. Idiopathically, hypoparathyroidism can be caused idiopathically, and post-surgically, hypoparathyroidism can be caused. So, how do we cause hypoparathyroidism post-surgically? When if you're doing thyroid surgery or thyroidectomy, parathyroid glands, which are a part of the thyroid gland, they are basically a part of the thyroid gland. They're small glands that are in the corners of the thyroid gland. They sometimes get excised. Normally, we try not to excise the parathyroid glands, but they do get excised in some cases. So, hypoparathyroidism after post surgical thyroidectomy is very common, and hypoparathyroidism is a part of post surgical thyroidectomy, right? So, you have to keep that in mind. How does hypoparathyroidism lead to hypocalcemia? Well, hypoparathyroidism will lead to low PTH, which directly reduces bone resorption, releasing less calcium. Renal calcium reabsorption is also decreased, and renal activation of vitamin D is also decreased. So uh, lower all three pathways lower serum calcium. All of these three are directly the functions of PTH. So when PTH is low, all of the three functions will not occur. That is how you will get hypocalcemia. How does vitamin D deficiency? It's very self-explanatory. Vitamin D would be less, dietary calcium absorption will be less, renal reabsorption will be less, and if the patient is uh, a patient of malnutrition, then of course he has a very decreased intake of calcium. So naturally, that would lead to hypocalcemia. Secondary hyperparathyroidism usually develops in vitamin D deficiency, uh, and it causes the serum calcium to rise a bit, but it doesn't really affect that much. It does more harm than the benefit. So that's why it is mostly a pathological state, although a physiological response, but mostly it leads to pathology known as renal osteodystrophy. So this is a bad thing that is happening to the body. Right? This should not happen. Chronic kidney disease again. The kidney would the kidney has two functions: to reabsorb the calcium and to excrete the phosphate. If the kidney is diseased, it would not be able to excrete the phosphate, so it would lead to hyperphosphatemia, and then it would also not be able to absorb calcium, so it would lead to hypocalcemia. Damaged kidneys also fail to activate vitamin D, reducing calcium absorption and causing skeletal resistance to PTH over time. So that's what you need to keep in mind, right? How does hypomagnesemia cause hypocalcemia? So what happens is that severe magnesium deficiency impairs both the secretion of PTH from the parathyroid glands and the action of PTH on the bones and kidneys. So, as we discussed earlier, magnesium is an important cofactor uh, for the receptors of the parathyroid glands that you need to keep in mind. How does acute pancreatitis cause hypocalcemia? Well, lipase mediated fat necrosis in and around the pancreas leads to saponification, which is soap formation, where fatty acids bind calcium, effectively removing it from the circulation. So there is what you may call a chemical reaction between the fatty acids and the calcium ions, right? So this chemical reaction would lead to soap formation, right? Saponification. And these fatty acids, they might come from trauma, or they might come from, in this case, they might come from uh, any end organ damage, specifically pancreatitis, right? This is what you need to understand, that this is the chemical reaction that is going on in the body, right? So that's how acute pancreatitis causes hypocalcemia. Massive blood transfusion or citrate chelation. So what happens is that citrate is an anticoagulant in blood products. So blood products, because they're sitting on the shelf for quite some time, we need some anticoagulant that is present in them, so that the blood doesn't get coagulated in by itself, sitting on the shelf or in the bag. So citrate is commonly used as an anticoagulant in those blood products. What does citrate do is that it binds the free ionized calcium in the recipient's blood, causing an acute transient hypocalcemia. So what happens is that if this is basically part of a vessel of a patient, and you're giving a lot of blood products, like you're giving a lot of packed, uh, not packed RBCs. Packed RBCs will not cause hypocalcemia because they're just RBCs. But if, let's say, if you're giving a lot of blood to the patient, right? This is whole blood. So this would have a lot of citrate. So citrate would bind with the calcium ions present in the lumen, leading to hypocalcemia. Right. So this is what you need to keep in mind. So these are all the etiologies that cause hypocalcemia. All of these etiologies that lead to hypocalcemia, I've explained each one of them. They're quite easy. There's not any rocket science mechanism behind them, but nonetheless, it is important for you to know them. So the physical examination now. Why do patients present like they do? Well, first of all, let's talk about neuromuscular irritability, so which is tetany, paresthesias, cramps, and convulsions. So why do patients get tetany, paresthesias, cramps, and convulsions? What happens is that low ionized calcium increases sodium permeability of neuronal cell membranes, lowering the threshold for depolarization. Right. This leads to spontaneous, uncontrolled discharge of peripheral and central neurons, causing muscle spasms and seizures. So basically, what we said is that when there is an increased calcium, there is increased threshold, right? So let's say this is the graph again. So when there was more calcium, the threshold was increasing, right? But when there is low calcium, the neuronal adaptability decreases the threshold, so that it is easier for the action potential to occur. But what happens is that again, this adaptability spreads across the complete central nervous system. So when the additive effect of this adaptability occurs, when the whole of the central nervous system gets adapted to this system, what happens is that this action potential starts to generate with even the slightest calcium present around it. Even slightest calcium activity would result in an action potential, leading to unneeded, uncontrolled, spontaneous muscle cramps, contractions, spasms, seizures. So that's what's going to happen, right? So again, keep in mind this is because of low calcium, right? And the opposite of it, depression of it, depression of the action potential, depression of the action potential was occurring due to increased calcium, right? So there is an inverse relationship between both of them that you must keep in mind, right? There is an increased inverse relationship. Okay. Classic signs, Shostak's and Trousseau's. We've already explained that tapping the facial nerve causes hyperexcitability nerve fibers to fire, leading to ipsilateral facial muscle twitching. This is the most you have to know about Shostak's sign. And for Trousseau's sign, ischemia induced by the blood pressure cuff further lowers the threshold. It further lowers the threshold for firing in the hypersensitive motor neurons, triggering carpal spasm. So let me show you a picture of the carpal spasm, uh, the Trousseau sign, right? So let me show you a picture of it, which will make things clear. So as you can see, that this is the spasm. This is the classical spasm. This is the classical shape, right? As you can see, this one. So that's what occurs. And now you know because it lowers the threshold even more for firing in the hypersensitive motor neurons, right? Cardiopulmonary symptoms such as dyspnea and laryngospasm they occur due to the hyperexcitability of respiratory and laryngeal muscles, leading to bronchospasm and laryngospasm, causing stridor and dyspnea. So although this is not the first symptom to occur, this is not very common, but this is the most dangerous, right? So this is the most dangerous, I would say, these one, because airway is now compromised. So this is the most dangerous. One thing more that I need you guys to understand is that the relationship of magnesium and calcium, magnesium and PTH and calcium, we've already discussed. Forgive me for that. We've already discussed this in our previous videos, but just as a reminder, is that the calcium is a cofactor for PTH secretion from parathyroid glands and is required for PTH action on target tissues as well. So normal magnesium levels are therefore essential for maintaining calcium homeostasis, right? Essential. So if there is hypomagnesemia, uh, then there will be impaired secretion of PTH, right? And also there would be PTH and organ resistance. So there's going to be two things. One is that there will be less PTH, and the second would be that the PTH would work less, and there would be an end organ resistance. So this would lead to hypocalcemia, that is refractory to calcium and vitamin D replacement until the magnesium is corrected. So you need to keep this in mind because this oftentimes is used as a subtle clue in the question. They're testing you for this relationship. Okay, so I think this is it for that. Yep. So this key fact I think now is explained why a hypocalcemia occurs in a patient after thyroidectomy, because parathyroidectomy also has occurred unwillingly. So the most accurate test again is ionized calcium and PTH. Uh, the patient has had parathyroidectomy. Review the operative note to determine if there was any potential damage to the parathyroid glands. The labs that you will do, of course, you will check magnesium. It's very important. You would check albumin. You would check the vitamin D levels. You will check both active levels and storage levels to understand the etiology better. You would check electrolytes. You would check urine creatinine to make sure if the kidney is functioning well. So BUN and creatinine would give you an idea of how the kidney is functioning, and you would also check alkaline phosphatase, right? You may check ECG. It shows prolonged QT interval. You may also check that. So again, this is the same thing. This is the albumin one that we all already discussed. Alcoholics are the most common patient population with hypomagnesemia. So why does this occur? Why are alcoholics more commonly vulnerable to hypocalcemia? Does anybody have an answer for that? Well, I'll tell you. So why do alcoholics develop hypomagnesemia? Is because there are multiple mechanisms for it. First of all, they have a poor intake and malnutrition. All right, so poor alcohol leads to poor dietary intake. All right, so this is one factor, but this is not important, not that much important. What is important is that due to the constant vomiting and diarrhea and malabsorption that occurs due to the chronic intake of alcohol, they lose magnesium a lot, right? And also, alcohol directly impairs renal tubular reabsorption of magnesium, causing excess urinary excretion. So this is a key and direct effect of ethanol. So this is the most important effect. The renal wasting effect is the most important effect. And after that, I would say the GI loss effect is more important, such as vomiting, diarrhea, and malabsorption. So these two effects you have to remember. These are important. And of course, you can also remember that alcohol causes malnutrition. So that's also a part of it. So that's how alcoholics are more prone to hypomagnesemia. So if you have an alcoholic in the question, you must think about this. All right. The treatment is simple for hypocalcemia. You treat the underlying disorder, and in most cases, you would have to give oral calcium supplements or IV calcium if there is severe signs such as a stridor or diffused body muscular spasms or contractions or tetany. And you also have to ensure that magnesium is repleted, right? So this is your these are your calcium disorders completed.